A very good evening to one and all. I'm Arpita, the moderator for today's session. The topic that we have brought up today is management of childhood asthma. And we have with us none other than Dr. Sanjay Chaudhary, sir, to approach this topic. Sir has done MBBS, MD. He is a senior consultant of pediatrics department at Fortis Hospital, Jaipur. So now I would request sir to please start with the session. Over to you, sir.
Thank you, Arpita. Thank you for IGCP for allowing me to discuss with the students of pediatrics and other specialties to discuss about the basics of asthma, uh, why we are worried about this increasing number of this entity, the number of these people affected by this emerging diseases
Sir, please
increasing.
speak a bit louder. Your voice is not very clear.
Okay, so so uh, today we are discussing about asthma, childhood asthma. We are seeing these children affected by asthma with varying severity in number, increasing number, which we used to see in our earlier days. So asthma, by definition, please definition. Next slide. So asthma is a reversible disease having a heterogeneous pathophysiology, and usually it is characterized by chronic, that is long-term airway inflammation. Airway inflammation that is affecting the airway, primarily the larger airways, from on a long-term basis. It has a defined by the history of respiratory symptoms such as wheeze, that is a musical sound coming from a hollow tube, uh, with varying degree of shortness of breath, that is the child is having a discomfort or the rapid breathing, feeling of chest tightness. Usually children do not are not able to complain about this specific complaint. They usually express by irritability or dullness or discomfort, cough, that is the episodic cough or spasmodic cough that vary over time and intensity. So this specific line is very important to discuss about asthma. In this, there is very variable problem, discomfort, um, shortness of breath, or wheezing that varies over time. Sometimes it increases suddenly, episodically, and resolves uh, very quickly with medication, many a times without medication, with change in environment. So this change in symptoms, a rapid change in increasing or decreasing symptoms, is a hallmark of this specific problem. Uh, there, variation can occur in intensity together with variable expiratory airflow. So this is a specific marker of this chronic airway inflammatory disease, that is we call it as asthma. It is widespread. Uh, it is not limited to a specific geography, and can occur in crowded places as well as green places in villages as well. And it is often called as reversible airflow disease or reversible airflow limitation. Next slide. So, why what triggers this inflammation? How it suddenly changes our environment or child physical state? There are certain triggers that initiates this allergic response. The allergic response in airways causes inflammation, increases the secretion, reduces the airway diameter, and child starts having certain complaints in form of cough, breathing difficulty, rapid breathing, feeling of discomfort, chest tightness in older children or adolescents, uh, clinginess, they, without presence of fever. Suddenly increases more commonly in late night, early in the morning, or sudden exposure to a noxious stimuli such as brooming or dust, molds, or there is some house uh, food preparation when mothers are giving some chalk in the to the sabji, or there is smoke or pollution in the home, and or there can be pets and pollens with flowering plants, or molds and damp fungus on damp wall. So these all can act as a trigger that can stimulate the airway, increases the secretion, increases the response of muscular airway, and that causes the diameter of airway to reduce, and child start having suddenly complaint in form of breathing difficulty. So uh, we need to identify the triggers, and we should ask the family to avoid these trigger, and it is one of the first primary steps towards controlling the asthma, preventing as well as controlling the asthma. Other triggers could be cold air, strong smell, cigarette smoking, or smokes. Next slide. Next slide. So, what could be the symptoms of asthma as I have discussed about you? So, it can present as cough, breathing difficulty, sudden episodic cough, uh, post tussive, that is post tussive vomiting just after episode of a cough. Excuse me. Hello. हाँ एक हाँ हाँ of sudden onset nature, where we have to exclude foreign body inhalation, or we have to exclude progressive symptoms of pneumonia, feeling of chest tightness, sudden discomfort in chest, or air hunger, uh, wheezing. It is a common symptom, audible symptom, where the parents express it. The child is having a fine-tuned सीटी जैसी आवाज on breathing, especially in late night, or the child when the child is crying. So this is the high pitched sound, and parents sometimes can notice this sound, and so we call it as wheezing. Or child can without any difficulty can have a spasmodic cough. Next slide. So, when we talk of ABC in our medical practice, so there are variety of ABC here. Here the ABC is airway hyperresponsiveness, chronic inflammation in airways, and bronchospasm, which is the hallmark of pathological event occurring in the airways. Next slide. uh, what are the inflammatory mediators that are interlinked with the allergens exposed to which the child is exposed? What it initiates inflammatory mediators, which is released by inflammatory cells, namely mast cells, eosinophils, and lymphocytes. Eosinophils are the primary cells which releases certain inflammatory mediators such as leukotriene, histamine, and cytokines, which initiate the cascading inflammatory response to the mucosa, as well as increase the constriction of airways. So leukotrienes, they are bronchoconstrictors, produces the mucus plug by hypersecretion of mucus and causes edema of the inner mucosal lining, increases the vascular permeability, and they also releases histamine, which act as a bronchoconstrictor, and it reduces the diameters, initiate a cough, breathing difficulty, itching at nose or eyes, and rhinorrhea, that is increasing secretions of eye and nose and nasal secretion. Cytokines IL-1, IL-4, IL-3, and IL-5. So they are increased by AGE production from eosinophils and recruit the mast cell uh, to increase the cascading event of inflammatory mediator. Next slide, Arpita. Next slide. So this is the photographic description of what the airways are suffering from on exposure to sudden exposure to an air allergen. So this is the normal cross section of airway, where the air is coming, entering the airway. Air There is a smooth lamellar flow from the larger airways to the air sacs, and it is controlled by this tube is controlled by these red lines, which are the muscles, smooth muscles, uh, encircling the airway. And on exposure to and on a cross, looking at the cross section, the the airway is lined by cells, columnar cells, which produces the mucus to lubricate the airway and to pull out the any infective or allergen material that has entered the airway. And the most outermost layer is of muscles. Next slide. So on exposure to sudden exposure to an allergen, uh, you can see in this slide, the as soon as the air containing the allergen comes in contact with the mucosal layer, initiate the cascading event of inflammatory mediators. So muscles get taut and reduces the airway diameter. So it is squeezes the airway, and the airway flow of air in these airway get turbulent. So the child start coughing, and in addition to this event, the internal diameter also reduces, and there is increases secretion of mucosa and inflammatory mediators that leads to the mucosal edema, which increases the problem of the child. Next slide, Arpita. So, what is the most important parameter in asthma when we look at is it airway hyperresponsiveness, it is bronchospasm, it is chronic inflammation. So these all depend upon what sort of patient. Uh, if there is bronchospasm is more prominent, or airway hyperresponsiveness, increased secretions in mucosa is more prominent. It depends upon patient to patient, and that we have to look for. Next slide. What happens in asthma? There is smooth muscle contraction around the airways, increases there is edema of the airways, as well as mucosal over secretions. That all these are all three events which increases the reduces the diameter, increases the secretions, and causes turbulent airflow, and so the gas exchange, gas available to the air sacs and exchange of CO2 is hampered, and person starts having discomfort or difficulty in breathing. Next slide. So, what to look for, how to go assess this child? We have to first look for the how this child is presenting to you having sudden onset respiratory distress, or there had been history of cough, breathing difficulty, recurrent breathing difficulty at night, but in day when the child is coming to you in your OPD, is now stabilized, having no breathing difficulty, but there is a history of cough and breathing difficulty at night. So this is the history which gives you a clue about the possibility of asthma, where you can see that the child having fluctuating episodes of increasing hyperresponsiveness, bronchoconstriction, increased secretion. But when the child is coming to you in your OPD, the child is having no acute symptoms. So we have to look for this part of history, then look for the family history, because in many of the patient, around 25 to 50% of the patient has a history of allergic disorder in first degree related, that is mother, father, or around 10 to 20% cases of second degree relative, that is bua, mosaji, fufa, bua, chacha, tau, like that. So we have to look for the symptoms in history, that there is persistent dyspnea and unexplained cough or audible wheezing to the mother. What investigation you have to offer if you are seeing the child for first time, or it has been the there is a history of sudden onset respiratory distress, where you have it is possible that it can be due to foreign body as well. So look for chest X-ray. Chest X-ray is not a mandatory investigation to diagnose asthma. It is investigation to exclude other possibilities such as foreign body uh, and pneumonia sometimes. Sputum and blood eosinophilia, where you take the secretion, sputum or nasopharyngeal secretion, and see the eosinophilic cell that initiate the inflammatory response, and there could be blood eosinophilia, that is eosinophil count more than 4%, or total absolute eosinophil count. Some authors say more than 350, some authors argue about increased eosinophil count over 500 cells. Serum IgE, that is immunoglobulin E, if it is beyond the range of normal range of for age and sex, then this is also corroborative event for symptoms of asthma. And then specific test, PFT, spirometry, or peak expiratory flow rate. PFT spirometry is more sensitive and diagnostic in comparison to PEFR, but whatever is available, we should offer the family so as to ensure that we are taking due care. Then there is a skin test to eliminate tuberculosis, that is MT. Other skin test to have a positive etiological diagnosis about what could be the possible allergen that has triggered this asthmatic response. Next slide, Arpita. Arpita, hi. So spirometry is one specific test that gives you an information about how the airways are behaving. It also gives you a detailed description of uh, about larger airways and smaller airways. So if you closely look as spirometry graph, then you over a period you will be able to differentiate between the larger airway response or flow rate response, as well as problems or flow rate of smaller airways. So start looking at these two graphs, and over a period you will be able to find the difference between the two, as well as it gives you measurement of total lung capacity. uh, it will give you in addition to total lung capacity, flow rate in first second, and in subsequently 2 to 3 seconds. So, and it when you give a bronchodilator and repeat this spirometric test, then it will give a difference between the that is bronchospasmic response as well as bronchodilator after the airways have been opened up with the use of bronchodilator. So it gives positive finding of increased total lung capacity as well as improved flow rate during the first post expiratory uh, volume in first second of uh, this spirometric test. Then there is a small equipment available which can be used at home as well to monitor and to watch the severity at home by the parents himself is peak flow meter. So there is small knob at the calibrating point when the person or child blow on the in this hollow tube. This knob gets swayed away with a force of air, gush of air, and how far it gets moved from the baseline gives you the gross clue about how his airways are behaving. It is not very sensitive, and is not can should not be used for diagnosis of asthma. Next slide, but it can be used as for monitoring home monitoring tool for asthma. Next slide, uh, bronchodilator reversibility test. So it is to be done with spirometry assistance. It measures peak expiratory flow rate or peak flow meter with peak flow meter or FEV on spirometer. Uh, take a response before giving a bronchodilator. Take FEV1 best response in of the three responses. Then give him a bronchodilator. 4 puffs of a bronchodilator commonly which we use is Levolin MDI. 4 puffs. Then repeat the test. Wait for 10 to 15 minutes. Repeat peak expiratory flow rate or FEV1 again. If there is a 20% increase in peak exploratory flow rate in PFR or 12% increase in FEV1 or absolute increase of 200 ml in FEV1, and it gives a clear response of bronchodilatory response, which gives a positive clue of air reversibility, uh, which where we can easily label a significant degree of reversible airflow obstruction, and which we call it as asthma. Next second, Arpita, next slide. So, what is the confirmatory test for asthma on spirometry? 20% bronchodilator increase in PEFR, 12% or 200 ml post bronchodilator increase in FEV1, or 12% or 200 ml from, I think B or C are same. So I think B is okay. Next slide. So as we know that asthma is a chronic disorder, a reversible airway disorder. So, this chronic disorder is due to airway inflammation, and reversibility is due to the bronchospasm. So we have to treat two things: bronchospasm as well as mucosal edema. So, thus, anti-inflammatory agent form the basis of asthma management, and bronchodilator are used for symptomatic relief. So, rest So bronchodilators are rescuers and anti-inflammatory agents are preventers. So we classify in these two things in anti-inflammatory as agents as preventer and bronchodilator are rescuer management part of this protocol. Next slide. So anti-inflammatory agent that preventers are corticosteroid. Corticosteroid are very important, has an important role in management of asthma and should be used appropriately. Parents should be informed about that it is steroid, but steroid has a beneficial effect and should be used. Should, there should not be any hindrance or feeling of using a steroid. So steroid is a wide class of drug class where there are good steroid to improve the quality of life, improve reduces the inflammation, reduces the disease severity, as well as there are steroids available to increase the weight or all those things which other people are taking for themselves. So it is a this inhaled corticosteroid is indicated medically, and this should be advised and informed to the family. Many of the times, if we are not, have not informed them appropriately, they stop using it with the feeling of that a doctor has prescribed him appropriately, inappropriately. Other anti-inflammatory agents are LTRA, leukotriene receptor agonist, antihistaminics. So they are preventer or controller which prevent the future attack of asthma, and uh, inhaled corticosteroid is a preferred choice because of the chronicity of nature of this disease. Bronchodilators are short-acting beta agonist and long-acting beta agonist. So they are, we call them as relievers or rescuers, provide only symptomatic relief. They do not have any effect on disease. So this should be very well informed to the family. This bronchodilator uh, gives relief, but it is not reducing the disease frequency, intensity, or duration. So it do not have any effect this beyond this relieving this present episode. So it should not be given as on a regular basis or beyond this where the symptomatic relief is not required. LABA is given in older children. LABA is given in combination with inhaled corticosteroid. So we have find that LABA in if given in combination and inhaled corticosteroid has a better ability to control as well as prevent the symptom as compared to ICS given alone. So inhaled corticosteroid plus bronchodilator combination is the backbone of asthma management strategy today, and it should be used against to all other therapies available in form of LTRA, antihistaminics. So they have a role, but they have a secondary role in addition to the primary role of ICS bronchodilator. They have a role in symptomatic management in certain cases where we are having difficulty in certain specific areas of asthma, specific subvariants of asthma. Next slide. Anti-inflammatory agents, corticosteroid such as beclomethasone, fluticasone, budesonide in form of inhaled steroids. LTRA, that is montelukast or zafarlikast, they are available as oral syrup or oral tablet medication. Antihistaminics, levocetirizine, fexofenadine, avastin, they are all available in oral as well as syrup form. And mast cell stabilizer, sodium chromoglycate, they have a very subtle effect on control of asthma. So it is not very much used in nowadays in management of asthma. Next slide. Bronchodilator examples: beta 2 agonists such as SABA, salbutamol, levosalbutamol, long-acting beta 2 agonists, salmeterol and formoterol. They are all available in inhaled form. Better to use them in inhaled form than to use that as oral or tablet form, because in the dose is very much different from inhaled to oral. There is a significant difference, and the side effects such as tachycardia, tremulous, chances increases with more of syrup form. Anticholinergics, epatropium and tiotropium, it is available. Uh, Many a times we use them in smaller babies where where the where beta 2 sensors are in less in density than in comparison than to the cholinergic receptors. Methylxanthines, which we are very rarely using, theophylline and toxyphylline. Next slide. So commonly used combination are levosalbutamol with beclomethasone, salmeterol with fluticasone, formoterol and fluticasone, formoterol and budesonide. So levosalbutamol is a small SABA, or salmeterol, formoterol are LABA, long-acting beta-2 agonist, and they are available in both with beclomethasone, fluticasone, and budesonide combination. Next slide. Why inhalers are better than the oral medication? Inhaled medication acts directly where it is required, that is to the lung airways. So the response is all time is also reduced, and the, the dose required is also reduced. So the side effects is also reduced, because it is hence the safety is 1 is to 40 of the oral dose. So there is significant reduction in side effect, and it is less expensive on long run. When you buy for the first time, it is expensive definitely, but on long run, it reduces the doctor consultation, hospitalization, emergency visits. So it in long term basis, it we are able to protect the airways, reduces the emergency visit. So it is found to be significantly less expensive than the oral medication. Oral medication takes longer time to act, reaches lung and all other part of the body by bloodstream, hence more dose required, and more side effects in form of tachycardia and palpitation or tremulousness. Uh, Relatively high, large amount of dose is required, and it is on long term basis it is more expensive too. Next slide. What are the delivery systems available? Oral, which is a uh, which is available from time immortal. Meter dose inhalers, meter dose inhaler with spacer, dry powder capsules with DPI device, nebulizing solutions with nebulizer. So these are various forms available for use. Out of all these modality available, MDI with spacer is the most recommended and most studied, and has the highest efficacy available with all the modalities available to us. Next slide. So this is MDI device, where you can see there is a plastic outer covering, and, and a small canister inside, which contains around 120 to 250 doses of the specified medication, which is in laminated or filled with propellant in addition to the medication drug. So whenever the person, family, father actuates or presses this, uh, the medication comes out along with the propellant in form of aerosol, very fine aerosol. Uh, when used with the MDI spacer, it enters the spacer compartment and stays there for few seconds. And when the child inhale with the every breath, it enters the lungs and deposit in the airway, larger or smaller airways, where this medication is most easily available to them and has a faster response time. Next slide. So this is a visual description of inhaler and the spacer. So top one is the inhaler, down one is the loose mouthpiece is a spacer. Next slide. Uh, this is a DPI device. It is a small device. It is modality of choice for the school or college going children, where they are able to maintain and able to carry this product in their pocket, and whenever they feel discomfort and they feel that they need this medication, they can go to the toilet and take this medication and come out. So it is not a bulky, very small apparatus, and can be kept in their jeans pocket. Next slide. And this third one is the nebulizer. So it is a bulky machine. Actually, it starts with electricity, where this medication is put in the chamber below the mask, and when the mist is blown from this nebulizer machine, uh, the air travels through this chamber and take the delivery medication to the mask, and when the child inhale this air, the air is medication is deposited in the throat as well as lower airways. Next slide.
So this is the last
Arpita,
slide.
next slide.
This is the last slide, sir.
Okay, okay. So I think I have briefly discussed about what are the possible, what is the asthma and what are the possible medications available to a child in a routine care OPD. Yeah.
Thank you, sir. Thank you so much for this beautiful presentation. Moving on to the questions that we have received from our audiences. So, so the first question is, what role does patient education, including training for proper inhaler use and understanding of asthma action plan, play in improving asthma control in children?
Uh, I think it has two to three questions embedded in this one. What is the question exactly?
Sir, what is the role of counseling in like
Yeah,
treating
yeah.
patient
So
education or patient counseling? Yes, sir.
yeah, counseling has a very important role where we have to discuss uh, with family about what is the uh, disease, why it is chronic, why child needs to be taken care at home on a long term basis, what are the triggering, what we mean by triggers, how to deal with this trigger in different seasons, where what precaution should be taken when we take the child on picnic or recreational places, uh, what is medication. What is why we are prescribing steroid when there is so much hue and cry about this steroid? Why still we are advocating steroid? And what is the benefit of steroid on a long term basis? What is bronchodilator? When to use bronchodilator? And how to increase or decrease the dose of either of drug, how, what is add-on drug. So these are variety of topics which needs to be discussed with the family before uh, prescribing or letting the family go home. And in addition to that, we have to describe how to use this inhaler as well as spacer. So these all things should be discussed with the family. Yeah. Okay, Arpita.
Right, sir. There is another question. How do environmental factors such as allergen, air pollution, or indoor irritants influence asthma management in patients, and what steps can be taken to minimize these triggers in children?
So, one of the easiest means of preventing is not acceptable to our society. One of the easiest mean is to use the mask. So, allergen will not be able to enter the airway, and it will not affect the child. But the society do not accept this modality of prevention. So we have to find the variety of ways how this child is index child is affected, and what are the triggers in their specific family. Is there any smoker in the family? Is there a crowded overcrowded places? How is the kitchen? Is there any molds or water seepage, or what is the is there any pet or dog or cow or dog in the family? What is the status of sunlight in the room where the child is most is sitting or playing in most of the time? What is the status of the plants or the shrubs growing around the family, or what is the status of traffic nearby to the house. So these are all the factors which is to be discussed one to one with the family, and then we can tailor made the specific answers for them. Yeah.
Thank you, sir. Thank you so much for answering the questions. And
Yeah.
thank you all for attending the session. Thank you once again, sir, for giving us your valuable time. With this, we would like to conclude the session here. Thank you, sir.
Thank, thank you, Arpita.
Thank you so much, sir.